guys, good evening. Can you all see me and hear me? So welcome to this class. We are going to be talking about spinal tumors, very important topic for exams. And you may also get a case, a long case, sometimes not very commonly, but it's an important topic for exams in general. Bone marrow lesions, yes. Let me schedule that for October first week, okay? So I'll keep it in October on bone marrow lesions. Any other topics that you want for next month, you can text on the group also, and you can text here. So I'll plan that because October schedule, I'm just going to plan now. So you can let me know, I'll incorporate those. One thing was about fetal imaging, right? So I have asked someone who does specialize in fetal to come and take a few sessions for you. So that's what's going to happen. All right, so let's start then. So, all right, okay. Congenital heart diseases, yeah, I'm trying to find the best person for it who does cardio rad. I unfortunately don't. So, I mean, I am not the best person to teach you that. So, just trying to find the right person. I'll ask somebody from cardio rad. I've been trying to talk to a few people. So yeah, hopefully by next progress and we can do that again. Yeah, because that's otherwise tricky topic. It's not very easy. So it is otherwise also very tricky. Even if an expert takes, it's very difficult to simplify that. So I will try, Let's talk about the exam, how you should be focusing on that. We have a class coming up on table viva, right? So let's talk about how to, deal with exams one more time. Okay, on that day. Yeah, Osborne series, my entire NeuroRad, all classes were based on literally Osborne, everything from Osborne. So we have more or less covered. Only whatever is left, I can take it up. Yeah, can do that. I love teaching, reading Osborne, but I've already done that for a lot of things. Like your entire last unit of congenital anomalies is covered. Tumors are covered. Head trauma is covered. White matter lesions are covered. So what is left in Osborne? Which unit? I think most of it is anyways covered. So we'll see if something is left, I can take that up as a topic. Yeah. Stroke is left. Yeah. Stroke as a big category is left. So I think Dr. Shashank had taken that up. That's why I did not take. But yeah. Okay, we'll talk about a timetable timetable and all. Now the thing is, I can make a timetable, but will you be able to follow it? It depends on how your duties are. So essentially, you have all of the topics in the app now. All you have to do is make up a schedule, try to cover 3 to 4 topics on a day-to-day basis. Start by reading the PDF of that class. Okay, and whatever part जो आपको नहीं समझ में आ रहा, see that from the video. You don't even have time to do all the videos all over again, right? So you can do the videos selectively, revise the videos selectively. So ये कर सकते हो that, first narrow down. In fact, every class that is there, is a potential topic. I was just looking at the paper. Somebody has shared the DNB papers of May, right? Almost everything we have already covered. So it's first make it a point to go through. There are like 160 lectures now. So go through 160 PDFs, not everything again. You can narrow down at least the ones which, are important from the exam point of view. Start with PDF. रोज का target रखो that 5 topics I have to cover every day. So you will cover a lot of ground in 1 month. So that way you keep checking off your list. So ऐसे ही होगा. Otherwise, it's not completable. No, you can never complete reading everything in radiology, but you triage the most important. So I can give you a list of the important topics, or we can do something of that sort. Let me take a class this week, okay? So I'll take it on 27th. I'll take a class on 27th, maybe just orient you a bit as to how you can go about it. Okay. All right. Chalo. Brain vascular, you have been asking for a long time. You are the one asking about CT angiography class. So yeah, we'll take that as well next month. We'll keep that in mind. All right, okay, so let's start about spinal tumors. So here my main focus is going to be intramedullary lesions, but I'm also going to be talking about an approach in general of how do we approach all kinds of spinal tumors. And in the end, we'll see some spotters of extradural lesions as well. But what's most important is intramedullary lesions. That's the focus today, okay? So these spinal cord tumors are going to constitute only 2% of the entire, intraaxial tumor category. So intramedullary tumors are only 2 to 3%. Out of these, it's very, very simple. As a starting point, 70 to 80% are either ependymoma or astrocytoma. And very simple, if it's a child or a young adult, we think of ependymoma. If it's an adult, older patient, we think of astrocytoma. So this is what you place your bets on, as soon as you see a lesion. And then there are some rarer lesions which we're going to be learning about. But overall, these go into your DDs as soon as you see that it's an intramedullary lesion. If it's a child, ependymoma, adult, astrocytoma. You can remember this as A and A, right? In case you forget. So this is what you have to remember. Oops. Sorry. I just inverted it. Ependymomas, yeah. My bad. So A not A and A. Ependymomas predominantly in the adults, whereas astrocytoma, particularly pilocytic astrocytoma in the children, right? So this is what you have to remember here. When we talk about spinal lesions here, that they are not going to present as acutely. So first of all, clinically, what you have to remember, clinically, these are not going to present acutely. So that's how you can distinguish them from a lot of other spinal lesions like demyelinating spinal lesions, ischemic like spinal cord infarct. They will have acute onset, whereas tumors are going to have insidious onset of back pain, and it increases with recumbency because of the mass effect. That is when lying down, they will have more pain. Audio is there, you have to join. You'll have to join the audio, only then you'll get. Otherwise, it's okay. Then plus minus radicular pain or neurologic deficit. Okay. So what you have to remember as far as the location is concerned, that astrocytic tumors like pilocytic astrocytoma and all, they arise from the periphery of the spinal cord, while neuronal like ganglioglioma will be central. So this also will talk about that how on axial we can localize and give a good list of differential diagnosis. So MRI is the workhorse. That is what we are going to do for all kind of spinal tumors. The routine sequences, these are the conventional sequences you'll do in every case. So this is what you have to do in every case. And then I'll talk to you about a few special sequences that you'll do for special indications. So T2, T1, post-GAD are done in two planes, sagittal and axial. Post-GAD is taken as fat saturated like always. STIR will help in certain conditions. We don't always take a STIR, but it's good to take one STIR at least, which is either coronal or sagittal. This helps in the characterization of extradural lesions and fat-containing lesions. So STIR you'll only do if you're suspecting fat-containing lesion, So sometimes you may have a lipoma, a spinal lipoma, you may have a dermoid cyst, you may rarely have an angiomyolipoma. We once had a case we saw, very rare, angiomyolipoma in the spine, extradural lesion. So these are three lesions. If you're suspecting that, then we do a STIR to see the drop-in signal, right? So these are the indications for doing STIR. Otherwise, we don't really do it routinely. Diffusion doesn't. I was saying the routine sequences, right? So we do STIR whenever we are suspecting any fat-containing lesion. The DDs for those, did you hear those DDs? Tell me, what did you hear? Fat-containing lesions of spine ke DD batao. No? Okay. Lipoma, AML, dermoid cyst. Good. Okay. Challenging, okay, because of the susceptibility of the bone, CSF pulsation, small size of the cord. So that's why these, require a lot of technical expertise from the radiographers. So that's the only thing. Otherwise, it is useful. CIS is very useful, and I'm going to show you these niche indications of arachnoid web and cyst, where we want to distinguish that is there a lesion or is it just CSF pulsation artifact, right? So when you see a CSF containing lesion like an arachnoid cyst within, the CSF space, we will need a CIS sequence in order to distinguish it from a pulsation artifact. So that's where CIS or Fiesta come in. GRE is useful for blood containing lesion, then we'll see Ependymomas very commonly you would know, right? Hemosiderin cap. So for that, gradient sequence is very useful, and this we do quite routinely. And screening, is also done whenever there's a spinal lesion for the entire spine to check for any other skip lesions or drop metastasis. So this is the protocol. CT, we do it mostly for extradural bony lesions, right? For extent, for cortical outline.